was our 20th year, and we're very specialized. So within the ortho group, I'm one of the spine surgeons. So we're going to talk a little bit about some of these advances that have occurred through my career. So I finished in 2003 with my fellowship at Rush in Chicago, and I've been here in Northwest Indiana ever since that time. And there's a bunch of these slides that talk about the way we used to do it. There's a lot of people that still do surgery the way we used to do it, and there's a beautiful swallow study here that really demonstrates something with some of the issues with the way that spine surgery used to be done, or cervical spine surgery. The big push for me when I first started was everybody, till date, comes into the office saying, I never want to have spine surgery. It's awful. Everybody does awful. Everybody does terrible. So for me, when I first started, it was exactly this. Is there an opportunity for us to go from fusions to motion preservation, which is what we're going to talk about today? And can we do these procedures and all procedures in a more minimally invasive fashion? So patients can go home on the same day or first thing in the morning, just like you see on TV. And can we do that on a routine, reproducible, safe basis? And so that's basically been the whole crux of my career, is driving that. And I've been very fortunate to be able to teach that on a national and international stage and really help drive the field forward. So again, when you think about spine surgery, I'm going to get a show of hands here, but long procedures, high complication rates, and the term I've heard more, and I came at clinic. They took a little break so I could come and give the talk. I'll go back to clinic. I heard it before I left clinic this morning. I will hear it in the afternoon. Don't let anybody operate on your spine. Has anybody else heard this sort of comment? Right, okay. I don't take offense. I hope that I'm part of the solution. So the whole key to advanced technology is that we can improve the outcomes, shorten the recovery period. And these are some of my colleagues that have also committed their careers to doing this. And so we put together this position statement. This was back in 2016 that was published in Spine, saying that we've basically broken through this glass ceiling. All of the things that we thought would be limitations from minimally invasive spine, we've now blown out of the water. So we're able to do a tremendous amount of work through these minimal incisions, minimal blood loss, basically eliminating transfusions for the vast majority of all patients, utilizing a lot of these techniques and technologies. So again, today we're going to talk a little bit about cervical disc replacement. So the disc here that's pictured is called the Mobi-C, and so Mobi, people think about as whoever's older in the room thinks about this DJ and making all kinds of this techno electro beats and whatnot. But Mobi C stands for really mobile core. So there's a picture of this device where the central core of the device really floats, and it's metal, and then that central mobile core. So this is a patient of mine. She's a nurse. And she was dead set against having a cervical fusion. She wanted to maintain motion in her neck. And she came and said, look, this is exactly what I want. This is how I want to be fixed, et cetera, et cetera. And everybody said that you're the guy to see for this. And so we did a 2-level disc replacement for her. The Mobi-C with Zimmer is the only on-label 2-level disc replacement. So it's the only one that you're allowed to do 2 levels on. In point of fact, the majority of the procedures I do are 1 level because I feel that the majority of patients' problems can really be honed down to 1 level. So these multi-level, 3-level, 4-level procedures in general, I think are, for the most part, not indicated and really should try to be avoided at almost all costs. And even 2-level surgeries are much the exception than the rule. I really feel that if you really focus and listen to your patients, you almost always can really isolate this to a 1-level issue. So the different concepts in motion preservation is either a metal on metal replacement or metal on plastic. And so there was this research I did, this is 1993, and I was thinking about showing a picture of what I looked like in 1993. So my first name is Nitin, and so when I was in college, they used to say Nitin hair. A lot has changed with my hair from that time until now. So I was going to go the before and after, but I left it out, trying to keep it a little bit more highbrow. But I did this research that looked at the plastic and the aging. So even before I was a spine surgeon, when I was an engineering student in college, I had done this research in New York on This is a knee replacement on the plastic here. And what's the best way and the best materials that could be used for this? And the study we used is the way they used to sterilize this was with this gamma irradiation. And once they irradiated it, the longer that the plastic sat on the shelf, it would start to degrade. And basically, I proved that. So, and this was as a college student. This was a very prestigious lab that I worked in. It subsequently got published in JBJS, which is a very prestigious orthopedic journal. Since I was a college student, they left my name off that publication because I hadn't even finished college. I was still, so they wanted to put like MD, PhD, PhD, MD, PhD, but for me, there was no BS, there was nothing. There was no bachelor's, I hadn't even graduated. So that was a great experience. I learned a lot, but frustrating that I didn't get my deserved accolades at that time. So I'm a huge believer in technology. So I was like one of the first guys with a Model X here at the hospital, and one of the first ones in Chicago. It's something I'm very passionate about, is pushing the field forward. The iPhone, the very, very first iPhone that came out, I had got, for my wife. And so this is like where my heart lies, in engineering and in really driving technology. I think that the possibilities for spine are equally limitless. So this was the video that I wanted to show you, that I'm glad we were able to get up here. So this is what I would call an over-the-top plate. So this is sort of the common way that people had done this historically, and so there's some research papers I wrote on this when I was at Rush, looking at this plating. One of my mentors, Dan Rue, talked about what's called adjacent segment disease increased with the use of this over-the-top type plating. And what you can see here is the patients develop these pretty severe osteophytes above this. A lot of this is being felt just by virtue of using this plate. And so we'll talk about some emerging technologies, both from the fusion standpoint and the disc replacement standpoint, that are zero profile. So you don't have anything sticking anterior. In essence, that should help decrease some of this adjacent segment disease. What's fascinating about this video, and I'll play this a couple of times, is it's basically a swallow study. I don't know, did anybody catch that? So what happens is in a swallow study is they make you swallow the dye. I'm gonna see if I can go slow here. And what you see here is as the dye goes forward, it's pretty thick, and then as it goes around this bump, you can see how narrow it gets there. Now that's incredible, because for years, people have talked to me about dysphagia after spine surgery. And I was like, how could a plate that's this thin create that much of an issue? Now, mind you, I'm an orthopedic surgeon, so I am somewhat simplistic in most of my philosophies. You would think it's maybe the soft tissue trauma, the approach, and so there was all of these different approaches. But the reality is, there's a tremendous amount of tissue that above and beyond where this is. When you operate, you see that there's almost like a rind of soft tissue that comes out here, and that's what's causing this obstruction. So this patient came to see me after seeing the ENT, saying he needs this level fixed now. So this guy had a problem down here, had surgery with a neurosurgeon in the area. I'd operated on his lower back, so he said, well, should you fix my lower back? Please help me with this problem. He said it needs fixed. So what we'll do is we'll go down in here and we'll have to trim this down, but then we'll take a zero profile device over here. And so I'll show you what we're doing now with this. This is a patient of mine where there was a two-level issue here. And instead of putting this over the top plate here, what we do is we operate at the level of the disc. So when I operate, I make an incision here in the front of the neck. I come down, I put a retractor in that shows me just this level. I'm not operating on this bone at all. There's something called Caspar pins that some surgeons use where they put a screw into this bone and a screw into this bone, and then they distract that open so that they can see the disc space. So I try to avoid that. The periosteum, the outer covering of the bone, once you violate that, the bone thinks it was fractured if you put a screw through this. So now this bone wants to heal. How does the bone heal? It forms more bone, right? So that's where I think part of these issues are that people aren't fully understanding. With this surgery, we made such a small incision that I literally cut the disc here and cut the disc here. I'm only operating in this disc space. So I've been out 16 years now, and I haven't gone back and looked at my own, but it is extraordinary for one of my own patients to come back with adjacent segment disease. The literature has a adjacent segment rate up to 20%, okay? I'm lucky if mine is 1%. And typically what happens to me is they come back and they have a problem. I've operated here, and then their problem is like somewhere completely different and remote. you know, it tends not to be that adjacent segment. And it's intuitive. When you look at this film versus that one with the plate, this just looks like it's, you know, a little bit more of a natural